Case management is a term which is often used when discussing healthcare systems, specifically in how best to allocate the often scarce resources available in order to assist those in most need. It has been used interchangeably with caseload management, and often individuals in healthcare roles find themselves becoming the de facto case manager for a particular long-term patient or patients. Case managers are often individuals with a significant number of years in an existing clinical profession who decide to change career. We caught up with speech and language therapist and retired case manager Angela Washington to talk to her about time as a case manager and gather some of the thoughts, tips and tricks she has learned from over 20 years in that role. Angela first qualified as a speech therapist in 1970 and has worked with adults with neurological disorders for over 40 years, both in England and Australia. She returned to the UK in 1984, where she continued to work with brain-injured adults in a variety of situations, and was also involved with the clinical training of final-year student speech and language therapists at Newcastle University. Throughout the latter part of her career, she worked as a case manager. In 1992, she was appointed the first brain injury case manager for Southern Derbyshire as part of the Department of Health's Traumatic Brain Injury Project, which became part of Southern Derbyshire's mainstream services. As case manager for Southern Derbyshire, she initiated the setting up and inauguration of Headway Derby in 1994, and from 1997 to 2000 sat on the management committee as secretary and chair and as a professional member of Headway Derby. She was an advanced member of the British Association of Brain Injury Case Managers, Babicom, from its inception, having been invited to become a member of the steering group which launched the association in 1996. She later served in various Babicom subgroups, education, information and development, and professional issues, and was a peer assessor for Babicom. In April 1997, she set up her practice as an independent brain injury case manager based in Derby. The practice expanded in 2010 to train an associate case manager who is now working on her own independent practice. Angela retired in 2014 and has been kind enough to spend time with us to help pass on some of her knowledge to other clinicians, patients and families. The first thing then is, what made you transfer from SLT to case management?
Well, by the time I did that, I had been working as a speech therapist for 2.5 decades, I guess, long time. And so I'd gone through various stages of speech therapy. I'd gone into management, and I guess part of it was that I really wanted to get back to work with clients again, because the trouble is that once you're in management you lose that contact.
So the reason why you went into therapy in the first place was
Exactly. And really, management's a different set of skills, and I did spend some time learning those, and actually they were very useful when I did case management, but that wasn't why I did the management skills. But it's what happens, I guess, or happened to me anyway, that if you're seen as, having particular skills, you try management, but it's a different job. So I guess at the same time that I was thinking, do I really want to carry on doing the management stuff that I'm doing, which I suppose I wasn't getting the same buzz out of. I was working at the Communication Aid Centre up in Newcastle on a 2-year contract, because the person who normally did that job was off doing a master's degree. So I guess it was a kind of nice way of just marking time. And I had a secretary in that job, which was rather nice. And she said to me one day, I suppose you've seen that job for a brain injury case manager. And I hadn't. But anyway, I went, I then looked for it, applied and got the job. So that was the journey into case management. But that at the time that was working, it was a pilot scheme that was funded by this was in the UK, funded by the Department of Health, really to raise awareness about brain injury. And because my clinical expertise, a lot of my clinical expertise was in ABI and traumatic brain injury, it was a good fit. So I did the project for 5 years, then all sorts of things happened. It was very successful, went into mainstream funding, but we were attracting, well, when I first started that job, they said they thought there would be 10 or 12 clients a year.
Yeah.
And for the population, which was about 250,000, I thought that sounded about right on the stats that we had at the time. By the time I left, we were getting not 10 people a year, but 100 people a year through the doors. And guess what? The funding was cut slightly. And I thought, I can't get to see all these people anyway. It needed more funding for more staff. So if the funding was cut, that really didn't feel good, but I really enjoyed case management, and there were plenty of opportunities to do it on an independent basis. So that's what I did.
And was the success of that because the more awareness people had of what to look out for, the more people were self-diagnosed, were being diagnosed as requiring assistance?
Yes, I don't think it was successful that much. I don't think we got the message out to the community at large. Well, the message we did get out, though, was within the hospital about brain injury. And we just, part of the funding was not just for case management, but there was some money that we were able to use to have an administrative person. And she got so enthusiastic about the whole thing that it was the consultant in rehabilitation medicine who worked out it was essentially a tick list of whether someone might have a brain injury. If you ticked all the boxes, the chances were they might well have a brain injury, and then they would be referred to him for a proper assessment. So I was rather peripheral to all of this, but involved, because obviously it would have an impact on my caseload. And she decided she was going to foot slog around all the hospital departments, which she did, even to the point of coming in really early to catch one particular ward when it wasn't very busy. I mean, it was extraordinary. But it was that approach that actually had face-to-face contact from the head injury team, which is what it was called, to, I guess, the lead nursing people on the different wards, saying, this is who I am, this is what I represent. Our consultant has drawn up this checklist, and is it okay if I come and talk to you on a regular basis about who's on your ward, who we might be able to help with? And that went down extremely well, and that's why we got that and actually that's probably a very focused way of trying to catch, and clearly we caught an awful lot of people that were being missed before.
And that's a big takeaway from that, is that it's such an unknown set of population out there.
Yes, Cool. It upset the funders, of course, because the implications were huge, but
it's clinical success and potential, but
yes.